Welcome to Championing Trauma-informed Care. From 2020 to 2021, while affiliated with Ascension Health, Our Lady of Lourdes in Binghamton, New York, and receiving support from Care Compass Network, I served as principal investigator of 2 IRB-approved clinical studies, which made the Lourdes Center for Family Health at 303 Main Street in Binghamton, New York, the first site in the regional system to implement a universal trauma-informed care training for all staff and physicians, and the first site to implement universal screening of adult patients for adverse childhood experiences. The studies showed statistically significant increases in the healthcare team's trauma-informed care workforce development, including awareness, education, and readiness to implement trauma-informed care, and increase in resilience, as well as patients' measured rapport with the physician and clinic staff team. After the conclusion of the studies, I allowed Ascension to share my modules with their 3,000 patient-facing providers and staff. Ascension Health follows in the footsteps of the leading medical innovators and institutions in the United States, and it is our hope that they continue to make high-caliber trauma-informed care training such as this part of their permanent workforce culture. As of 2019, the majority of people currently living in the United States have experienced at least one kind of adverse childhood experience, and that includes both the patients who come to institutions such as Ascension Health for care, and the providers and staff members working at the institution who help care for them. Trauma-informed care seeks to be an antidote for the effects of adverse childhood experiences. Why do we want to know about this? Because we want and need, according to the science, to do things differently. Adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. Again, as of 2019, the majority of adults in the United States have reported experiencing at least one adverse childhood experience before age 18. Now, it must be noted that having an ACE score of 1 does not mean that an individual experienced only one traumatic event in their life. It simply means they experienced only one category of trauma. But as is usually the case, most individuals experienced multiple instances of that same trauma in their lifetime. There are health impacts of trauma and adverse childhood experiences. The healthcare providers featured in the following video and videos to come are participants in Advancing Trauma-Informed Care, which is a national initiative supported by the Robert Wood Johnson Foundation, whose aim is to suggest practical ways for forward-thinking healthcare institutions to both understand and practically implement trauma-informed care in day-to-day operations.
People are complicated, people are not just, what you see, and they're not just like vitals, and they're not just, let me, check your breathing. It goes deeper. Like if you go through some personal stuff, like some personal trauma, I think that it's gonna affect you medically.
How can you ask someone about their body? How can you ask somebody about their mind and not recognize their experiences in the world as they're living in that body, as they're thinking and having that mind? It really is about recognizing people as whole beings and not just body parts. To me, that's trauma-informed care.
The majority of illnesses and conditions that people are treating in primary care settings are trauma-related, especially the ones that are the real hard issues that clinicians and patients are struggling with: substance use, chronic pain, obesity, things that providers are struggling so hard to change and help with and failing and feeling really frustrated about.
So if they really want to know their patients and really want to help them in this deep level, then, learn the trauma-informed care way.
One of our most beloved patients was murdered in this really terrible way by her husband it awakened us to the fact that actually we weren't doing a very good job. We were effectively treating HIV, but when we scratched a little bit beneath the surface, we realized that 30% of our patients have PTSD, over half of our patients are depressed, 40% of our patients are using hard drugs, and then tons of women and people living with HIV across the spectrum are dying from preventable illnesses.
I think the widespread impact of trauma and toxic stress on physical health is what has been the missing link.
It's linked to poor health in later life, heart disease, any kind of cardiovascular disease, early sexual, multiple sexual partners, early pregnancy, mental health issues. They're all related to those adverse childhood events.
I experienced patients that were behaving in ways that were really stressful, cursing, yelling, really heightened emotions at the front desk, in my office, breakdowns. We might naturally ask ourselves, what is wrong with that person? Trauma-informed care is really about saying, what happened? Why would a person behave that way? Rather than what's wrong.
We want to give people good care, but we want them to thrive. Not just be healthy, but thrive. And it's very hard to thrive in this community.
Exposure to potentially traumatic events happens across all socioeconomic backgrounds.
Many, if not all, of our patients have a history of trauma, and also so do most of our staff. And that plays a big role in how people interact with each other and how patients do or don't take care of their health.
If you're going through some personal stuff, you're not going to want to take your meds. You're not going to want to take care of your health if you're depressed, if you're going through some mental health stuff. So I think that it's all related. It's all interrelated.
I think one of the biggest frustrations that I've seen from my medical colleagues is frustration. Like, oh my gosh, I keep telling this patient the same thing over and over again. How many times are they gonna come in, not listen to what I recommend, and then have the same symptoms and then keep coming back for the same symptoms?
And in medicine, typically what doctors do is they give advice. They tell you to eat healthier, they tell you to exercise, they tell you to check your insulin. And honestly, the medical field has been doing this for decades after decades after decades.
One of the things when someone reviews your programs, we have this for some grantees, and they want to know how many people have had a hemoglobin A1C done, how many people's blood pressure is under control, how many people have had check on whether they smoke. Those things are all important, but you could look great on that and not be giving good care. So we want to know about people's lives. How has your life changed?
This is clearly working. And I can say that really confidently, based upon a number of things. First, the effectual experience for providers is dramatic. I mean, our experience as providers has changed from being overwhelmed, from having a chaotic clinic, from telling each other, the worst war stories possible as a way of coping, which is actually really just re-traumatizing. To an experience where we're feeling like we are doing the absolutely best job possible.
When I first came here, just the greeting alone, just changed my mind about going to other doctors and so on, because the way you were treated. And you could see their true concern about your welfare. I picked that right up from going to different places. So I came back again, and I came back again, and next thing I know, they told me they had a gym here. I didn't know that.
People come willingly. They're using more services, so they're understanding that their health is not just that medical service, but it's what they eat, how much you move, and the state of your soul.
People that were kind of struggling with substance use and trauma and homelessness, it's not like that has gone away, but what we've seen is people kind of having longer periods of stability. Like maybe they've actually have now like found decent housing and they're doing harm reduction with their substance use, or they're sober from substances for a period of time, then maybe they slip, but they get back in touch with us more quickly than they used to.
When we're viewing people more as a whole person that has had life experiences, rather than a caricature of their behavioral reactions, we start to then make another shift from being stressed out from this person to then being more empathetic. We then shift our behavior. So if I look at someone and I say something's wrong with them, then that might give me permission to behave in ways that are not helpful. And so when I say what happened, then I am now mentally thinking, how can I help this person? Is there something that I can do that can make their experience better?
Once you start communicating where you're not being dictated to, you know, someone is actually asking you, how do you feel about this? And how, you know, it builds that trust. You know, it's like, wow, they actually heard me, you know, and I see it.
The staff or the clinicians, your medical care provider, are not just interested in your HIV. It's like, okay, your T cells are this, your viral loads that. They're more interested in your life. So you're able to talk about things, I guess, that maybe led up to being at risk for HIV from your past. And the providers, they're better able to communicate, I think, with us. And it makes us feel comfortable to talk about whatever. We know we're not going to be judged for, you know, for our lives.
We did not come down here and say, by the way, we're putting a health center at 11th and Parish. People wouldn't have used it. So this way they were part of the process. In our original building, they helped design it. They met with the architects. And so this was and still is a very strong community partnership.
What I've learned taking care of people with really intense trauma is a lot can happen just by understanding why people are acting the way they're acting.
This idea that trauma-informed care and becoming trauma-informed is this huge, heavy lift. In truth, if we don't provide services in a trauma-informed way, what is the heavy lift is services that are not effective. And so what trauma-informed care means does not have to be the most elaborate, detailed, research-heavy, protocol, assessment-based approach. It can start with education and then kind of move forward.
The training piece is really key, and it doesn't need to be expensive or too time-consuming. We have 3 core trainings that we have everyone go through when they start working here, and the modules can be done in 2 hours or less.
This change process is incremental, and you can begin this as an individual person in your clinic and make a meaningful difference, not only to your patients, but to you as a practitioner. It's not radical to think that our job as primary care providers and why we went into primary care in all of our different disciplines is to actually help patients heal. I mean, that's not radical at all. It's self-evident, but it's like taught out of us. And what we're doing now in this movement towards trauma-informed primary care is to teach that back in, is to help people realize that their vision for why they went into this to begin with is to help people heal and to connect with them in that process, and to heal themselves in that process, and to have joy in that process.
Man is the only animal that cries because man alone sees the difference between what is and what could be. And I think that's the hallmark of public health. We don't just look at something and say, isn't it a shame there's so much trauma? Isn't it a shame there's so much obesity? But it doesn't have to be that way. We're not going to fix it, but collectively we can work on it. So that's the quote that guides me very often. It doesn't have to be that way.
Members of this community deserves a good, healthy, happy life.
What is trauma? Trauma is an event, a series of events, or a set of circumstances experienced by an individual that is physically or emotionally harmful or life-threatening and has lasting effects biologically throughout their life. In clinical practice, there is a screening tool for adverse childhood experiences. It screens for 10 different categories of trauma. If an individual has experienced a particular category of trauma, they receive a score of 1. To remind you, as of 2019, the CDC has stated that the majority of Americans have experienced at least one of these 10 types of trauma before age 18. Individuals can be exposed to trauma when they are alone, as an individual, or as part of a group during a single episode of mass violence. Trauma can be experienced directly, and the majority of Americans have experienced such, but trauma can also be experienced indirectly. This is called vicarious trauma. It's when you experience firsthand repeated descriptions of trauma that others have experienced. Vicarious trauma is very common in healthcare workers and those in the healthcare fields. Now let's look at the CDC Kaiser Permanente ACE study, the original study that allowed later clinical tools, such as the ACE questionnaire, to come into being.
In the final analysis, it's clear that adverse childhood experiences are a major or the major factor underlying the 10 most common causes of death in the United States. The ACE study grew out of innumerable counterintuitive observations that we made in the course of operating a major obesity program. And being forced by patients, first to recognize the frequency of childhood sexual abuse, then of major household dysfunction during the developmental years, the ACE study represented our desire to determine in a general population the prevalence and long-term significance of these problems that we really had not thought about before in adult medicine. This is the sister of our original patient. Listen to what she says.
As far as being molested, that's stuck with me all my life. You know, it's still in the back of my mind. I am in therapy. I too suffer from depression. Yeah, the most traumatic was my mother, losing my mother, most definitely.
Which had the most to do with your putting on so much weight?
That's a hard question. I think I started getting heavier and heavier after my father and mother divorced. But then I started really getting heavy after the molestation. And I would try to take it off, and then I would just gain it all back and then some.
I'll tell you briefly our general findings to provide you some skeletal outline to hang the factual data on. We found, as you all know, that adverse childhood experiences are very common but largely unrecognized. They are powerful predictors of later social functioning, well-being, health risks, disease, medical costs, and death. And they are thus the basis for much of what we do in adult medicine, and of many major public health and social problems. They're complexly interrelated, not solitary, and that combination of high prevalence and great penetrance makes adverse childhood experiences the leading determinant of the health, social, and economic well-being of the nation.
ACEs changed the landscape. It changed the landscape because of the pervasiveness of the ACEs, the huge number of public health problems, expensive public health problems, depression, substance abuse, sexually transmitted diseases, cancer, heart disease, chronic lung disease.
20, 25 years drowning out some poor childhood experiences with drugs, alcohol, cigarettes. Gotten rid of the drugs, got rid of the alcohol. Next thing I got to get rid of is the cigarettes. And I had no idea that the nicotine played such an important part in keeping that door closed.
In keeping the door closed to?
The memories that I've blocked out with all these years with the alcohol and the drugs.
So you see what's happening to you now as related to what happened to you decades ago?
Yep. I found a way to block the emotions and the memories.
With?
Drugs, alcohol, cigarettes.
We decided that we would study 10 categories of adverse childhood experience.
These are all things where there was already great systems involvement or interest and that were potentially modifiable.
We picked 3 categories of abuse. Major physical abuse, I'm certainly not talking about spanking, I'm talking serious beating. Major emotional abuse, recurrent humiliation. You are the stupidest kid that I've ever seen. You know, your father and I really didn't want a child when you were born. Or as a patient said to me fairly recently, his father used to often say, you kids ought to all be taken out and shot. So 3 categories, and the third category was sexual abuse, contact sexual abuse, not somebody flashing a kid. 2 categories of neglect, emotional neglect, physical neglect, and 5 categories of major household dysfunction. Growing up in a home where a mother was treated violently, growing up in a home where one of the members of the household was imprisoned during your childhood or adolescence, growing up in a home where one of the members was a drug user or an alcoholic, growing up in a home where one of the members of the household was chronically depressed, suicidal, mentally ill, or in the state hospital, and growing up in a home without both biological parents. We saw that if any category was present, there's an 87% chance that at least one other category would be present, and a 50% chance of 3 or more categories. And we saw that women are 50% more likely than men to have an ACE score of 5 or more. This guy became obese as a child after his parents divorced, and he was sent to live with his violent alcoholic grandfather so that his mother could work.
It wasn't that I ate because I was hungry. It was, when I look at it, it was just a place for me to feel safe. As a child, I remember there was a point, I would probably say, all the way from kindergarten to, God, I don't know what grade, but I used to get beat up all the time. All the time. And when I got the weight on, it didn't happen.
As the ACE score goes up, the likelihood of chronic, self-acknowledged chronic depression goes up, so that at ACE score 4 or higher, you're bumping a prevalence of 60%, 60% in women and about 35% in men. We will look then at self-acknowledged suicide attempts. And what you see here is that as the ACE score goes up, the likelihood of attempting suicide at some point later in life goes up dramatically. And we've moved from a straight line progression, an arithmetic progression, to an exponential curve. And at ACE score 6 and higher, we're wildly off the scale because there is between a 30 and 51-fold increase in the likelihood of later suicide attempts compared to A-score 0, a 3,100 to 5,000% increase. And I remember vividly when one of the epidemiologists at CDC told me that numbers of that magnitude occurred once in the career of an epidemiologist. And then here we are looking a half century or more later at prescription rates for antidepressant medications, and we see the same stepwise increase as the ACE score goes up. The likelihood of being prescribed antidepressant medications, more or less a half century later, goes up in the same stepwise progression. So it would appear that depression often has deep roots going back into childhood. Looking at coronary artery disease, pretty much everybody knows since the Framingham study that there are certain commonly recognized underlying risk factors for coronary artery disease: smoking, hyperlipidemia, diabetes, etc. And it's easy to forget that about 15% of the time, none of those risk factors are present. So how do those people, without the conventional risk factors, end up with coronary disease?
I'm going to pick up the thread here and sort of summarize what we saw a little bit earlier in the Kaiser Health Plan, as Vince described. Here's what we saw, and this is a brief summary of the publications that we've done in the scientific literature. ACEs have a strong influence on adolescent and reproductive health, smoking, obesity, alcohol abuse, illicit drug abuse, sexual behaviors, mental health, risk of re-victimization, that is, intimate partner violence and sexual assault, stability of relationships, and performance in the workforce. ACEs increase the risk of dying young, having heart disease, chronic lung disease, lung cancer, liver disease, autoimmune diseases, suicide attempts, injuries, intentional and unintentional, as well as the risk for infection with HIV and getting sexually transmitted diseases. So what I had concluded, and I think Vince had also concluded as we got into this, is that ACEs determine the health and well-being and are the major determinant of the health and social well-being of members of the Kaiser Health Plan. Take a minute and take a look at this table. This is from the Washington Family Policy Council, which really began spearheading this whole effort in the early, around 2000. They've been at this for almost 10 years. This is the summary of their surveillance of ACEs in the state of Washington. As with the Kaiser Health Plan, prevalent diseases, cardiovascular disease, cancer, and asthma have a graded relationship to the ACE score. Risk factors: smoking, drinking, obesity, risk for AIDS, taking painkillers to get high, marijuana use, poor mental health, sleep problems, frequent mental distress, nervousness, requiring medication for emotional or mental symptoms, or emotional problems that restrict daily activity so you can't live your life and function normally. Fair or poor health, being dissatisfied with your life, poor quality of life, and health-related quality of life measures. And they very cleverly, and this has been alluded to, this is an intergenerational problem. So what they did is they put these outcomes in adults as risk for intergenerational transmission, that is, affected people transmitting their biologic experience to their kids. Depression, anxiety, emotional problems, drugs or alcohol, or loss of a parent. This was our conceptual framework, a life course model from conception to death with adverse childhood experiences through neurobiologic and other mechanisms leading to social, emotional, and cognitive impairments, risk behaviors, disease, disability, and social problems. And what we saw there and what we see in the state of Washington is adults go up the pyramid. If they have children, what happens to their children? The ACEs that they got from their parents become the ACEs for their children. These risk behaviors, disease, disability, and social problems are dying young are ACEs for their children. So this is a circle. The ACEs get passed down to their children, biologically back to their children. I think the most important thing that contributes to the information of the ACE study is simply the powerful nature of when people tell you the truth about their lives and you listen, you understand their life course.
It's made me realize how much of what we see in adult medicine is the result of what was present but not seen in pediatrics.
And it's just not a social worker's problem. It's just not a psychologist's problem. It's not a pediatrician's problem. It's not a juvenile court judge's problem. It's everybody's.
I believe that this is the most important thing you can ever do, which is begin to deal with this intergenerational transmission of adversity that causes so many problems in our society.
As we saw in the video, adverse childhood experiences have lasting effects on a person biologically. They affect health, they affect behavior, and of course, they affect life potential. As one's ACE score increases, so do the negative health outcomes in that individual. So, what is this antidote to adverse childhood experiences? What is trauma-informed care?
You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made. Plus, our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
When implemented correctly, the recipient of trauma-informed care should feel the following 5 emotions be elicited. The individual receiving trauma-informed care should feel safe, should feel like they have choice, should feel like they have collaborators, should feel trust, and lastly, they should feel empowered. These 5 emotions are the direct opposite of the emotions felt during trauma. When an individual undergoes trauma, the individual feels unsafe, the individual feels like they have no choice, the individual feels alone, like they have no collaborators, the individual doesn't have any trust or very little trust in others, and lastly, the individual feels anything but empowered. Because of the mind-body connection, individuals who have undergone trauma can become re-traumatized when they are placed in situations that have the 5 or any of the 5 bad emotions felt during trauma. So, which is to say, if someone's life is not imminently at risk, yet they are in an environment, say a hospital or doctor's office, where they feel like they have no choice about an issue, that can trigger in them a re-traumatization, a re-experiencing of the original traumatic event that traumatized them in the first place. As you may guess, because we don't know people's trauma history, if we don't operate through the lens of trauma-informed care, we run the risk of re-traumatizing them. And these individuals can either be our patients or they can be our colleagues. So let's see how trauma-informed care can reverse the health effects of adverse childhood experiences. Preventing or reversing the effects of ACEs could potentially reduce some of the most common medical comorbidities in adulthood in the United States today. Things such as diabetes, cancer, stroke, asthma, kidney disease, COPD, depression, coronary heart disease, overweight, and obesity could be reduced or prevented. Risky health behaviors such as smoking or heavy drinking, socioeconomic challenges, unemployment, less than a high school education, or not having health insurance. Preventing ACEs or reversing the effects of ACEs could positively impact millions of people with health conditions in the United States. Operating with a mindset of trauma-informed care in the healthcare workforce can benefit the health, well-being, and professional productivity of providers and staff. There are significant and quantifiable consequences for operating an organization or oneself in a way that is not trauma-informed. Resilience, besides being one of the 2 cornerstones of trauma-informed care, is associated with greater job satisfaction, work happiness, organizational commitment, employee engagement, improved self-esteem, sense of purpose, improved employee interpersonal relationships. Employers reap the rewards of increased productivity of their employees. Employers experience reduced turnover rates of employees, and employers experience reduced burnout amongst their employees. As we've already learned, trauma-informed care consists of resilience and empathy. Because the majority of Americans have experienced trauma, all Americans should be constantly building their resilience. Most of us have great amounts of resilience already, but those of us who work in healthcare fields also need to have great amounts of empathy. This is our ability to build rapport with patients, to build rapport with our colleagues on the healthcare team, to impart our wisdom to patients and colleagues, and to share with them our wisdom and the ways that we've succeeded in increasing our resilience and the knowledge that we have as part of our professions. Empathy is uniform amongst all individuals. It's the ability to connect and sense the feelings of others. However, resilience is more customizable. Building resilience can look different for different people. Some of us are stronger in other areas than others, but for most of us, resilience consists of building in these 4 areas. Firstly, taking care of your body, daily physical activity, eating healthy, having sufficient sleep, taking time to recover from exhaustion or illness, finding meaning and purpose, volunteering, being part of a larger community, whether or not that includes a faith-based community, asking for help before you need it, or asking for space before you need it, practicing presence, mindfulness meditation. It also includes setting and keeping boundaries, being assertive in our approach and our communication, learning to say no so that we can create relationships that are safe and allow for appropriate connection. It includes gratitude, also known as affect meditation. Gratitude can be expressing gratitude to your friends, family, and colleagues that you appreciate. It can include spending time thinking about what you're grateful for. It can include designing a gratitude journal where in the evening at the end of a day, you write down 3 things that you're grateful for to look for the good. Studies from the Max Planck Institute in Germany showed that gratitude type meditation, also known as affect meditation, not only has the ability to strengthen resilience, but specifically can improve empathy by strengthening those areas of the brain that are involved in empathizing. Lastly, in our 4th category of resilience, we have our social support networks. These are nurturing relationships, whether they are with our family, our friends, or our colleagues or mentors, spending time with friends who don't drain you of energy. These 4 categories are broad enough, simple enough that we can be building on them right now.
This idea that trauma-informed care and becoming trauma-informed is this huge, heavy lift. In truth, if we don't provide services in a trauma-informed way, what is the heavy lift is services that are not effective. And so what trauma-informed care means does not have to be the most elaborate, detailed, research-heavy, protocol, assessment-based approach. It can start with education and then kind of move forward.
The training piece is really key, and it doesn't need to be expensive or too time-consuming. We have 3 core trainings that we have everyone go through when they start working here, and the modules can be done in 2 hours or less.
This change process is incremental, and you can begin this as an individual person in your clinic and make a meaningful difference, not only to your patients, but to you as a practitioner. It's not radical to think that our job as primary care providers and why we went into primary care in all of our different disciplines is to actually help patients heal. I mean, that's not radical at all. It's self-evident, but it's like taught out of us. And what we're doing now in this movement towards trauma-informed primary care is to teach that back in, is to help people realize that their vision for why they went into this to begin with is to help people heal and to connect with them in that process, and to heal themselves in that process, and to have joy in that process.
In closing, I'd like to remind you that trauma-informed care does not have to be a burden to adopt. Trauma-informed care is simply resilience plus empathy. We all can start doing that now to help our patients and to help our friends, our colleagues at our respective healthcare organizations.